87 and 87.
We'll try and save your fingers.
All right, well, good afternoon. I'm going to start us off here, and then we're just going to work our way down the table. In your roles, thank you so much. In your roles as representatives and senators of our great state, you are certainly going to hear from your constituents that healthcare is too costly and that access and availability is very difficult in our state. And without really getting into, sort of agreeing or disagreeing with those statements, I want to really walk you through some of the reasons why those might be the case. Now, most people would be a little bit surprised to find out that the cost of healthcare differs not by any other reason than the source of the payment, right? So if you're Medicare, Medicaid, commercial insurance, you can have the same service that someone else has, and the cost will be different. When you look at the way that's already there. When you look at the way that we're spending dollars in the United States today, already 52% of all the dollars spent on healthcare are spent through some sort of governmental entity, whether it's a state Medicaid, Medicare, TRICARE, employee benefits for the federal folks, state employees, et cetera. That leaves the other 48% sort of in this fragmented state of commercial healthcare, so all the big payers like Blue Cross and United and Aetna and the like. Now the issue is that numerous studies that have been done by academics and nonpartisan groups have said that Medicare and Medicaid tend to pay less than the actual cost of care. Right around 90 to 98% is sort of the range. So if you can imagine this, as hospitals and physicians and organizations are trying to run a business, a significant portion of the revenue that they receive is for patients, and that revenue is insufficient to cover the overall cost. In our case, in rural Western North Carolina, we tend to be, you've already heard it today, right? We tend to be older, poorer, and sicker in the rural areas than we are in the urban areas. And as a result of that, that means that the shift is much greater toward having Medicare, Medicaid, and the uninsured populations in our region, and very little of the overall commercial cost. Now, when you think about the underlying cost of care, the vast majority of that is actually people. If you look at a hospital system, 60% of the overall cost is related to the nurses and the physicians and the technicians and the administrators and so on. In addition to that, they have costs associated with implants and pharmaceuticals and those items as well. So if you start to think about this and say, okay, well, if the underlying cost, giving people raises, which is appropriate, we have to retain and keep the nurses, as you saw here. There's pressures on the system everywhere. If we're going to have underlying cost increases of, say, 3 to 4% a year, which would be relatively modest, it has to come out of the relatively small portion that you can negotiate with the commercial payers. So you're going to hear from employers say, gosh, I'm seeing my costs go up 8, 9, 10, 12% a year. It must be those greedy hospitals or those greedy doctors or what have you. It's not. It's simply a function of it's the only place to get those increases, and that's why you're hearing that particular issue or concern. I'm going to leap ahead a little bit here and dive down a bit more on what this is all about with respect to the differentials in the cost here. If you're an employer-sponsored plan, like the Uniteds and the Cignas and the Aetnas and so on, you can see with the inpatient care, it can be 1.5 to 2 times as much, right, to pay for the same service that a Medicare or Medicaid beneficiary would pay, basically 1 times. In case of the outpatient care, it's 1.6 to 3.6. It's a pretty big delta. And then with physician care, it's about 1.15. Think about that in terms of primary care, and 1.85 sort of high-end specialty care as the big differences. And all of these costs are being passed on to the employers, right? Because it's not Blue Cross paying it, it's Blue Cross going to the employers and getting the increased premiums in order to cover those differentials in the cost and the rest. If you look at this just tells you how this problem isn't getting any better. That first slide that I showed you that said 52% of the dollars are coming from state and federal governments, that's been changing at about 1% a year for the last 4 or 5 years. So just think about that. And then this is part of the issue. It's because all of America is getting older. It's not just the workforce in healthcare that's getting older that Dr. Hathaway referred to. It's also all the rest of us, right? Except for well, Amy's not getting any older, but all the rest of us, we're all getting older. And what I also want to kind of talk about is when you think about these dynamics, the economics, what's driving all of these types of issues about access and availability. I'm at 5. Okay, I'll speed it up. Like an auctioneer here. When you think about the economics of it, it's what drives things, right? So if the economics aren't there, it's going to create an environment where we have greater problems with access and availability. And so this will just sort of tee it up for you. We have seen closures in our region. We've seen labor and delivery closures. Now, some of that has been because of quality and volumes, but the other part of that has been because of the economics. It just doesn't work. And it's a shame that we have that situation because it leads to poorer outcomes in rural areas. You're looking at 6 to 8% worse outcomes just because you live in rural America today. That's part of the problem. And then it's further, it's a bigger problem when you think of Native Americans and Black Americans where, as you can see from this graph, that should be unacceptable to us. A lot of my colleagues here have heard me say this over and over again. It seems like we just continue to admire the problem rather than to actually address it. This data, if I had pulled this for you 20 years ago, would show the same exact thing. So we have an opportunity to really start thinking about how do we change the environment? You have to change the economics. I'm going to head more, but I didn't realize it was going to take me that much. So I'm going to turn it over to my colleague, Caitlin, and she's going to pick up the ball from here. So thank you.
Okay. So hi, my name's Caitlin, and I have been tasked with helping you to understand the current landscape of maternity care in Western North Carolina. So as a mother of 2 small children, I'm going to ask you to use your imagination. So I want you to imagine a pregnant patient in our beautiful mountains, think 29 years old, has 1 or 2 children, works full-time. Her pregnancy is not alarmingly high risk. She does have gestational diabetes. And so she will need some extra monitoring twice a week in the last 6 to 8 weeks of her pregnancy, as long as it does not get worse or become high risk. Because of her geographical location, and I also want to acknowledge that I'm sitting on the low end of how long someone might travel for prenatal care in Western North Carolina, she's driving about 30 miles one way for each appointment that she has. The average pregnancy needs 10 to 15 routine visits, and we need to add at least 8 of those visits for the extra monitoring that she will need at the end of her pregnancy. This means this patient will travel roughly 1,380 miles for care during her pregnancy. She will spend roughly that many hours in the car. This does not count the number of hours she spends sitting in the waiting room, being seen and addressing any issues that she may have. I also want you to add in the fact that she works a standard 9-to-5 job, must use her sick or vacation hours in order to make it to these appointments. I'm not even getting into the childcare that she's going to need for the other children that she has. I'm not getting into the fact that maybe she doesn't have sick and vacation hours, so she's not getting paid. And some employers also penalize their employees if they are taking sick time that they don't have. So I asked you to imagine this. Unfortunately, this is the reality of most of the pregnant women in rural Western North Carolina. So as Mark mentioned, oh, I have a map slide. Sorry. Hang on. Nope, went the wrong way. Sorry. I'm nervous, can you tell? Okay, so this is a map that I actually created because of my position at MAHEC OBGYN, and each diamond represents the offices left in rural and urban Western North Carolina that still provide prenatal care. So these closures over the last 7 to 8 years also resulted in a mass exodus of OBGYN providers. And as you can see here, this means that the landscape of prenatal care and postpartum care in Western North Carolina is sparse, to say the least. Not to mention the units that are left, there are 7 of them, and within those 7, there are 4 competing hospital systems. They do not talk to each other. They do not share medical health record information. So again, I'm going to ask you to use your imagination. This time I want you to be a physician or a nurse in a rural emergency room. It's 2 a.m. on a Saturday, so medical records offices are closed. Also, it's a full moon. If you're a nurse in here, you know what that means. You have a patient walk into your labor or into your ED. This ED does not have a labor and delivery, but they're coming here because it's the closest ED that they have at their disposal. She is in labor, she is bleeding. You do not know her blood type, her risk factors, how far along she is, or what you will need to take care of possibly a premature baby. Also going to throw out, I do have the data for the premature delivery rates for 2020 in every single county in Western North Carolina. As a healthcare professional, that is scary as shit. Okay? So I just want you, and that is real. That is happening. Dr. Sullivan has experienced it. Dr. Dixon, who is a colleague of mine and also works in Macon County seeing OBGYN patients for MAHEC, she has also experienced it. And these are some statistics that you can look at. Again, I have more statistics, but there are currently, and nobody check my math, okay? There are currently 55,730 women of childbearing age in only the rural counties, so 12 out of 16, only the rural counties in Western North Carolina. These women and birthing people need more options. I don't have all the solutions. I do have some suggestions. It would be great if we could reassess payment models in place for prenatal care and deliveries, especially when these two things are happening in two different hospital systems. We have women and birthing people who are getting their prenatal care, which is making no money for anyone, in one healthcare system, and then delivering at a hospital in a different healthcare system, and that is where all the money is going. With 63% of deliveries in Western North Carolina between the years of 2016 and 2019 being covered by Medicaid, specifically a change in Medicaid reimbursement could be the difference in a rural labor and delivery unit staying open or having to close its doors, as we have seen in the past few years. What if we had a region-wide password-protected database that kept record of all the pregnant patients in Western North Carolina, which is a long-standing dream of my colleague, Dr. Suzanne Dixon? Of course, these competing hospitals would have to agree, and HIPAA restrictions would have to be figured out, but that's a problem for legislation. So that could mean that no matter what hospital a pregnant patient shows up at in Western North Carolina, the information that the providers and the healthcare workers need to take care of her would be at their fingertips, and we are able to save that bleeding mom, we're able to save that premature baby, and we're able to get them the care that they need. I'm done now. Sorry.
Yes, some tough folks to follow. Again, my name is Lori Stradley. I serve as the Executive Director at Impact Health, which is the network lead for the Healthy Opportunity Pilot Program. And at risk of being too optimistic, I get to talk about some asset-based solutions. So I'm going to lead with and end with my hope for this work, which is to sustain it and expand it. We're already seeing some pretty incredible impacts, and I took a big risk. My next slide has AV in it. So we're going to see if we can play this quick overview video to give you just a little insight into how this process works. Oh no. It's always the audio that gets you.
Works hard.
Give it about 10 seconds and then I'll just start talking again.
You're gonna get it.
I know you got it, Maya. I'm just very aware of the minute fingers that are about to start raising. In order not to lose any of your time or attention, I'll just do a little bit of a quick overview, and if we do get it playing, it'll be wonderful. But the Healthy Opportunity Pilot is innovative. It is North Carolina innovation on a national stage. This is the first initiative of its kind in the country to leverage Medicaid investments to fix upstream healthcare problems, not just examine them or try to connect to services. We have a fee schedule that supports our Medicaid managed care members who are eligible for the pilot in living better, safer lives. We have multiple domains that are supported in this formally. Part of the pilot is to connect with food access and make sure that regardless of where you live in our region, you have access to fresh fruit and vegetable and healthy, nutritious meals for your family. Another domain is in housing. We know that it is very difficult to navigate the housing market and then to establish long-term safe housing. So there are support pieces there. In addition to that, we recognize that transportation is a huge barrier to living a healthy life in a rural setting and really anywhere. And then we're about to go live with our toxic stress and family safety that will help us support families who are navigating personal violence and parenting skill set in order to, again, stay healthy and well.
She lives in Western North Carolina.
You got it, Maya, go ahead.
This is Jennifer. She lives in Western North Carolina, works hard, and loves her daughter, Olivia. After fleeing an abusive relationship, Jennifer leaves her home and finds a barely affordable apartment in a neighboring county, but it's miles away from her full-time job. Jennifer used to take the bus to work, but buses don't service this area, so she must buy a car. With new bills stacking up, Jennifer struggles to make ends meet. Buying fresh, healthy foods just isn't in the cards right now. As spring arrives, Jennifer notices mold in her apartment. She reports it to the landlord, who does nothing to address it. Over the next few months, Olivia develops a persistent cough. Jennifer wants to keep her home from preschool, but can't afford a sitter or the income lost from missing work. A visit to the local clinic results in an asthma diagnosis for Olivia. When the pediatrician asks about their living situation, Jennifer says,
"Well, there's mold and the landlord won't do anything about it. This is the only place we can afford."
You need to find a new place to live, or your daughter will continue to suffer. Is there anything else going on that is making it difficult for your family?
There are thousands of families just like Jennifer's, and Impact Health is reimagining what healthcare and being healthy means for them as part of North Carolina's Healthy Opportunities pilot program for Medicaid. Working with care managers, we are able to connect medical providers and insurance companies with nonprofit and other community partners who provide services for housing, transportation, healthy food, and interpersonal safety, so we can help families address essential needs before they turn into health issues. Why? Because greater well-being for Jennifer and Olivia means reduced healthcare costs and stronger communities for us all. Together, we can build a healthier future, making a generational impact in Western North Carolina. To learn more, visit impacthealth.org or call the member services number on your Medicaid card to see if you qualify for the Healthy Opportunities pilot.
So now you can see why I'm so optimistic and excited to be able to sit up here and talk about this. This work currently supports a slice of our North Carolina Medicaid managed care population. And those who are already engaging are getting the help that they need. That story was based on a real experience, a real mother and child in our community. And they have talked about it, how it has fundamentally changed the trajectory of their lives. I also want to talk just a little bit about what's happened so far. This is a very new approach, and we are already seeing the way that it's stabilizing the assets that are present in our community. One of the beautiful pieces of this pilot is that it didn't create new nonprofits and new organizations. It leveraged the assets that exist right here already. There are phenomenal nonprofits and human service organizations across our region that already do this work. And this allows them to stabilize, to expand their capacity, and to bring in a different revenue stream that allows them to serve more people in the ways that they have already been doing the work for decades. And you can see here that it's also an economic engine in our region. Just in the 9 months since we have launched these programs, we have already seen our human service organizations draw down over $1 million in reimbursements for the services that they're providing. These funds also support full and part-time positions across our region. 194 people have some or all of their salaries paid by this new investment in the region. And we work with over 50 human service organizations across the region. The other piece that we find incredibly important, we've been talking today about how complex these systems are. It's almost impossible for a full-time working parent to navigate all of the systems and resources they need. So we leverage what's called a no wrong door approach. One of the other pieces of having these communities with long-lasting relationships, community health workers who already know the people in communities, they can connect to resources and simplify and get people the support they need as quickly as possible. So wherever your trusted relationship is, whether it's with your physician, it's with your community health worker, which is still at work, we haven't figured that out completely yet, or it's with a human service organization that already knows that you're dealing with food insecurity in your family, that's how we bring them into the program. Oh, I didn't give you, oh, I did give you, there it is. And the last piece, I would really like to explore this further with all of you. Right now, this is part of a waiver, and it is a pilot, so it does have a time frame on it. We want to keep doing this work. We want to serve more than the individuals who are currently eligible, and we want to keep going. We think this is one of the ways that we can truly meet the healthcare needs of all individuals and families across the state, starting, of course, here in Western North Carolina.